So hello and welcome everyone. My name is Alison Schneider and I am the Education and Training Manager at AgeWell, Canada's Technology and Aging Network. In today's AgeWell webinar, identifying ways to make the virtual emergency department more accessible for older adults, we will explore the virtual emergency department that has been operating out of Sunnybrook Health Sciences Centre since 2020. AgeWell has funded this research since 2024 in a project entitled Co-Designing Outreach Strategies and Educational Materials for Virtual Emergency Department Uptake by Older Adults. I'm excited to have both the project leaders here today with Sandra Hitzig and Justin Hall. They're going to speak with us about how to make virtual emergency departments more accessible. Dr. Hall is an emergency medicine physician and chief of the Department of Emergency Medicine at Sunnybrook Health Sciences Centre and the medical director for Toronto's Virtual Emergency Department. Dr. Sandra Hitzig is the program research director of the St. John's Rehab Research Program at Sunnybrook Research Institute. So some housekeeping. The presentation will last for about 45 minutes. And then we'll have 15 minutes for the Q&A session to follow. So that means we're looking for you to post any questions or comments for the Q&A, either in the chat or in the Q&A box. And you can do this throughout the presentation, but we won't get to those questions until the end. You may also raise your hand to ask a question verbally. So you'll see that raise hand icon there for you to use. And we'll do that during the Q&A session. You may also enable closed captioning in Zoom, and that's located on the Zoom toolbar. This webinar is being recorded and will be available for replay on AgeWell's YouTube channel. And we'll send that link to all people registered for this session as well. Okay, so without further ado, I will invite Justin to kick off the presentation.
Thanks, Alison, for the kind introduction, and I'm glad to be speaking on behalf of our team here to start, and my colleague Dr. Hitzig will join me after as well. So our study team is a broad and diverse group, and I won't go through everyone's name here, but what you can see is we do have a range of trainees, we have a patient partner, and we have a number of community organizations that have supported this work and what we're going to present today, so I'm grateful for their contributions as we go forward. We'll start as well with a couple funding and disclosures. So we did receive AgeWell funding for this through the Healthy Aging Canada Research Program, or the HARP program. We've already declared in terms of our current roles and how we're funded for some of our own time for Dr. Hitzig and myself. And then we don't have any other conflicts of interest to declare today. As we go through this presentation, just as bookmarking, we're going to be talking about older adults and the emergency department and the experience that they often have in emergency departments. We'll then be speaking briefly about the virtual emergency department in general. And then we're going to look in more detail about some of the studies that we've done, specifically around a chart review, which is a quantitative assessment that we did of older adults who have used the virtual emergency department. And then we'll be looking at qualitative findings from our studies as well. And then concluding with a few next steps in terms of where we see this going in the future. So to start, we'll landscape to Sunnybrook ED. Our Sunnybrook is one of Canada's largest hospitals with approximately 1.3 million patient visits per year. We are an academic health sciences centre that is fully affiliated with the University of Toronto, and we are part of a major research network here as well. In terms of the emergency department, we are open 24/7, and we do serve a very complex patient population with approximately 60,000 visits annually. This includes those as a regional stroke center, a STEMI or heart attack center, neurosurgery, and cancer care, among many other specialties. When a patient arrives at the emergency department, the first person they'll typically see is a nurse. And that nurse will use what's called the Canadian Triage and Acuity Scale, or the CTAS scale, to be able to assign a score to the patients in terms of a timely goal for seeing them. Doctors and also physician assistants then see patients based on the urgency of their condition and not necessarily based on the order in which they arrived. And probably many of you have seen many different media reports and articles over the last several years in terms of emergency departments and how they're often in crisis. So emergency departments are faced with treating patients from an aging population, hospitals that are often over census and have difficulties flowing patients throughout the entire organization, and having critical healthcare staff shortages. And overall, this creates an environment which is often challenging for both patients and providers to work in. We also know that many emergency departments, including our own, often function at peak or over peak capacity for weeks at a time, which places further strain on the care that can be provided. On the right-hand side, you'll see a screenshot of a CMAJ article which described how unnecessary ED visits in Ontario are often due to other system forces. So specifically, not having access to timely primary care, and a significant proportion of visits for conditions that could be managed in potentially a primary care office or some other doctor's office, or virtually in some cases. There's also some other reasons why there may be a better care location. So some of those include social and mental health needs and other community organizations that can help in those cases as well. So what about older adults specifically, and what are their utilization patterns of emergency departments? When we look at Ontario, about 25% of emergency department visits in Ontario are by older adults. When we look at Sunnybrook, this is even higher at about 38% based on our most recent data. And there's many different considerations for what happens or why this can be often a challenging experience for patients. Older adults often have more mobility issues. They may have chronic pain. They may struggle with sleep deprivation, especially when they may stay in hallways or lack of ideal care spaces for them. And they may have difficulty interacting with nurses and physicians. This could be due to overstimulation based on hearing or sensory overload as well. We also know very clearly that those patients who do stay in the emergency department longer are often associated with higher rates of delirium, and this is approximately 10% of older adult patients, hospital-acquired pressure ulcers, increased risk of falls leading to other injuries, and often other conditions that might arise from being in the healthcare environment longer. So what is a potential way of getting around this? I'm going to now share our virtual ED model, and briefly I'm going to start with some key messages and then go back to a bit of the history. So there's 4 things that I'm hoping that everyone can take away in terms of this experience. We know that in Ontario, virtual urgent care continues to grow, and it also supports safe and timely care access. It does align with the provincial model, specifically to offer the right care in the right place at the right time by the right provider. We do know from our personal experience here that most concerns are addressed in an outpatient manner without the need for a transfer to in-person ED care. And the patient experience through the virtual ED is extremely positive. So let's take a step back in terms of our background and how did we get here? If we look back to the early days of the pandemic and in early 2020, we saw an opportunity where many patients were actually not coming to emergency departments, and teams across Toronto and other regions were quite concerned about this. We did a postal code analysis, and as part of this, we realized that patients from different equity-deserving populations, including older adults, were more hesitant to come to the emergency department. So we saw an opportunity here because we really wanted to make sure that patients were getting the care that they needed. And so Sunnybrook, along with University Health Network and previously Unity Health as part of St. Michael's in Toronto, partnered to deliver a virtual urgent care experience in Toronto. And there were many things over the next months that we looked at to be able to deliver this in a way that best supported our patients. The first was we wanted to explore what is the feasibility of this new type of model of care. This was not something that had been done in Canada or the US or in many other international locations. We also wanted to be able to collaborate on a regional approach to try to prevent duplication of resourcing here. By coming together, we were also able to offer longer hours of service and improve access for patients throughout the region. And finally, we tried to leverage economies of scale to promote long-term sustainability. So here's a picture of the evolution of our program. So in 2020, we launched, and this was initially with emergency department physicians. These were dedicated physicians who were not working in the department at the time, but were trained at a given hospital, and so we're very familiar with logistics and processes there. In the next year, in 2021, we did do a nurse practitioner triage pilot at UHN. And part of this was to try to understand if there was a better opportunity, either with technology or with a person, to help with triaging to make sure that the patients we were serving were the best types of patients and were appropriate for virtual care. The following year, we did an expansion of the nurse practitioner role. We then launched a common website so that patients had a one-stop shop as to where they could go to be able to access information around ED virtual care. And we also developed this digital front door across our sites. This then led to a transition as a result of Ontario Health making some decisions to do a NP-led model. And then we also had an ED-MD who was available for support as needed. So this is someone, again, who was not working currently in the emergency department, but would be available for consultation, potentially for cases that might be more challenging, or to sort out logistics of patient transfers as needed. We then added and launched full translation services that are available in real time for these assessments as well. And finally, as into this year, we've had ongoing collaboration with our regional partners, and we've seen greater integration now with Ontario Health's Health 811. This is the service whereby patients can either call in or use a chat system to be able to connect with a nurse, to be able to get direction on where their care needs might be best met. And finally, as we're looking forward, what we've been working on this year is really combining or having a hybrid model of both in-person and virtual care and trying to make the connection between these two environments as seamless as possible. I wanted to share a screenshot of the type of data that we collect because I think data is our most valuable resource here in terms of understanding our population that we serve, where they come from, and how we can better serve them as well. So this just gives a screenshot of the data that I have for every day, and we can sort this by different categories or time points. You can see on the upper panel the age distribution of our patients. On the lower panel, you see a map, and the postal codes are where we've had patients come from. We certainly try to serve those who are closest to our hospital because we know our resources the best there. However, there are times where patients might have been visiting from another location or where we've actually been asked across the province to help when capacity or access has been a challenge in other regions also. We assess and we track whether a patient has a family physician, and about 80% of our patients do have a family physician, but sometimes the issue is not having one, it's the timely access to having one. And then we do track in terms of where the nearest emergency department might be, not only in terms of understanding the population that we serve, but also in terms of potentially where we might need to redirect a patient for in-person care. The next thing that I wanted to share is, so you might be wondering, well, what sort of populations or what types of conditions would you see? This is a schematic just showing some of the types of conditions that we see, and these are largely in groups related to viral illnesses, for example. This includes skin rashes, sometimes eye conditions. And one of the other things that's not on here is often there's a lot of advice given in terms of navigating the healthcare system. So where might be the best place for someone to have follow-up, potentially to get a specialist, or to get a prescription, or potentially a social service. Highlighting some of the major populations that we serve, when we look at our proportion of the different types of presentations, we have lots of patients who do come for some type of imaging or laboratory test that we're able to help them coordinate, and again, without using the emergency department. Abdomen pain, which mirrors that of the in-person emergency department, is a very common condition. Early pregnancy concerns, for example, some bleeding or spotting that might happen during pregnancy, or potentially cramping and wanting to ensure that the pregnancy is still safe. Minor injuries, so sprains and strains, minor falls, for example. There are also others in terms of system navigation, those viral illnesses, and chest pain. So what happens when you come to see one of these appointments? So currently, our patients see a nurse practitioner as the first line, and as needed, sometimes there will also be an emergency physician who's directly involved in that care. And there's many different outcomes that would result. The first, and sometimes the most common, is actually that we provide reassurance to the patient, and we also provide those next step guidance in terms of what is required. Sometimes we will be able to address the acute issue that the patient is presenting with, and then we would refer the patient back either to their own family physician or their own nurse practitioner if they have one for further follow-up. In many cases, we do provide a specialist referral. In others, we might provide a prescription or other investigations, for example, completing some blood work, checking a urine, ordering an ECG or X-rays. And finally, for the smallest group of our patients, sometimes the condition might be best served by an in-person assessment. This might be to facilitate a physical exam for the patient or to arrange certain tests that would just be required in a more timely manner. So looking at the last year, what you can see on the slide here are some of the data to reflect what has happened over the last fiscal year. So about 19% of our patients are unattached or do not have a regular family physician or nurse practitioner that they see. Of the patients that we've seen, 92% were able to be managed virtually without a need for transfer to an in-person emergency department. 12% had a consult where the nurse practitioner saw the patient, and then an ED physician was asked for further advice or potentially to support logistics or for due to complexity factors. You can see a small proportion of our patients did receive a referral to a specialist. A small proportion also received potentially a medication or a prescription refill. And lastly, about 12% required some type of investigation, which might have included blood work, ECG, urine, or X-rays. So what about the patient experience? So over the last 5 years, we have approximately a 95% patient satisfaction rate. And I think it would be hard to find an equivalent in-person emergency department across this country that would have a similar positive satisfaction rate here. Many patients rate this much better than in-person care. The technology has actually been very easy to use, and this is across all age demographics. We also asked patients what would they have done if this service was not available. And approximately 70% of them say that they would have come in person to the emergency department without this service. And finally, the overall recommendation rate, that is, who would recommend this service to a loved one, a family member or a friend, is about 95% consistently. So we've talked a lot about our history, where we've come from, our current state, and what about the future? So there's two big areas in which the virtual ED has been quite beneficial and where we're looking to expand. The first is supporting emergency department diversion. So this would come through expanded partnerships and outpatient redirection. What I mean by this is being able to have pathways that support our clinical teams and partners. This might be arranging for someone to follow up at a community health center. This might be arranging for imaging or blood work on an urgent basis, but not an emergent basis, but in the community. The next area that we're looking at, and we've already started this pilot locally, is empowering our emergency department triage nurses to be able to divert patients to virtual care. So we've come up with a series of guidelines locally whereby a patient who might be presenting to the emergency department, and if there are particularly long waits, would be given an opportunity to have a virtual appointment instead when there's availability. Often this leads to a shorter length of stay for the patient and a better patient experience, again, with the right type of patients. And finally, we've used now the Virtual ED to support our quality assurance program with the emergency department. We are able to review test results and provide treatment and follow-up via phone or video with patients, answer questions that may have been unanswered during their ED visit, and also to follow up to connect patients with a primary care physician as needed or if that wasn't able to be achieved during the visit itself. So I've just alluded to primary care. And so the second big area in which we are strengthening our work here is around primary care connections. And you'll see a series of areas here on the slide. So the first is our gold standard would be to have patients are able to follow up directly with their own primary care provider. And this is to support continuity of care. So this is certainly not a replacement to a family physician. The second, we've recognized that it's often hard to be able to find a family physician. So over the last many months, we established a bridging or unattached clinic at Sunnybrook in collaboration with our family health team. So this is now a 6-month program to allow short-term connection to a family physician while we're working towards permanent attachment for a patient. We've also partnered with what's called our North Toronto, Ontario Health Team, as well as Vibrant, which is a community organization that now has capacity to support permanent attachment. As part of Ontario's strategy for what's called the Primary Care Action Team, we're looking at a way of building a virtual PCAT. This would leverage our existing infrastructure and referral pathways from our local hospitals, as well as Health 811, that is that nurse triage, so that we're able to connect with providers that are closer to home for patients. And finally, we're recommending and trying to strengthen our opportunity to allow primary care providers to use the virtual ED for questions that they may have prior to advising an emergency department transfer. An example type patient might be someone who has leg swelling, where the primary care provider is worried about a potential deep vein thrombosis or a blood clot. And so what can happen is by having a call with us, we may be able to arrange for that ultrasound or that treatment outside of the emergency department, as sometimes patients will come to the department, but we may not have the ultrasound available or the capacity at the time of day that a patient's arriving, only to be told that they would have to come back the next day. So we want to be able to strengthen the opportunity so that this leads to a better patient experience as well. So bringing this all together, so who are we looking at? One of the things that's come out of our work is trying to strengthen access and awareness. So we're looking at our unattached patients, our high ED users, those who use the emergency department as their primary care point to seek care, and for equity deserving populations. And so how are we suggesting doing this? There's 3 different ways. So online or virtually, in person, through word of mouth, for example, or community hubs that would expand our access opportunity. And to do this, one of the equity deserving populations is that of seniors.
So I think I'll take over at this point. So as you've heard from Justin, the virtual ED became a widely used service during COVID, and we know that virtual models of care overall were accelerated during the pandemic. Now, in terms of my own engagement, how I got involved in this work was that I participated in Sunnybrook's digital health and virtual care task force during the pandemic to help figure out which technologies were being used across the hospital to provide care, and to use that information to inform policies to ensure that we had the tools and policies in place to address this rapid and sudden shift to virtual models of care. So during my tenure on that committee, and as Justin had mentioned, I learned not only about the virtual ED, but that there were some questions being raised about who was accessing it or who was aware of it, because there was a notable decrease of underserved communities coming to the in-person ED during that time. So with that in mind, I connected with Justin, and we got funding to explore the virtual experiences, virtual ED experiences of people from different equity deserving populations. So these were people from racialized communities, the 2S community, persons with disabilities. So we had a very broad net to see, people who felt being underserved, to see what their experiences were like. And what we did was a series of qualitative interviews, and we managed to interview 43 virtual ED patients, 7 of their family members, all with varying and intersecting identities, who all shared how the virtual ED offered them a culturally safe experience compared to the in-person ED. So things like other virtual models of care, people felt that they didn't have to travel to the hospital, they didn't have to go through the long waits. For some people with mental health conditions, sitting in the waiting room could really contribute to anxiety. In some cases, it minimized discrimination, and not necessarily with the interactions with the physicians once they saw them, but generally going through the booking process or dealing with others in the actual in-person ED was when these instances of discrimination were experienced. People also felt more control over the care experience. Again, during the pandemic, the number of people able to go into hospital was limited, so virtually they could have their family members attend. And everyone generally talked about how they didn't feel rushed during their appointments. They really felt that they had the time to talk about their issues. Next slide, please, Justin. So, while this was great to learn that the set of patients were very positive about the virtual ED, we still know that there are a number of barriers to accessing and using virtual models of care. And again, this could be due to a lack of internet, not having devices, if people have low levels of digital literacy, or if they're experiencing language barriers. So all of this can make accessing digital care, virtual care, much more difficult. Next slide, thanks. So, while our earlier studies on the virtual ED were not focused on older adults per se, some people we interviewed talked about how older people, let's say with hearing or visual impairments, may face additional struggles to using the service. We would hear, oh, my father would never be able to figure this out because, he has a hard time using the computer. So these things around older adults were coming through from that earlier work. However, and from another study unrelated to this, a colleague who was providing community-based care to older adults in the community told me that they were teaching their older adult clients about the virtual ED for certain urgent conditions. So this, along with the combination of the findings from our earlier work, really inspired the current project that AgeWell has funded. And as Justin mentioned earlier on, many of our hospital patients are older adults. So we felt it was important to do a deeper dive to better understand the nuances around the virtual urgent care needs of this particular population. So from our funding with AgeWell, we wanted to better understand how the virtual ED could serve to better meet the health needs of older adults and to find ways to raise awareness and increase its uptake. And so the way we're doing this is through 3 related activities. One is going through the charts, seeing, which older adults have used the virtual ED over the past 5 years. We're interviewing patients and their family members about their virtual ED experiences. As well, we're talking to providers to see what they think about the virtual ED and how it could be used to enhance patient care for this population. And then coming up, we'll be mobilizing the findings from this research at a World Cafe in January to co-design some strategies for better serving our older adult patients. And a World Cafe is just a get-together with some structured discussions to get some specified feedback in terms of a path forward. And it should be noted that while we're in the thick of the data analysis, and so, we're being busy beavers and going through everything, what we're going to share today is mostly preliminary, but I still feel it provides some really good insights about the virtual ED and its use by older adults. So in terms of the chart review, we extracted data from the inception of the virtual ED all the way up to January 31st, 2025, where we took a look at the patient demographics, visits, the reasons why they visited it, outcomes, and ED revisits. And so from this 5 years worth of data, we saw that older adults who were 65 years and older only made up about 13% of all virtual ED visits. So when compared to the in-person ED, where the rates of older adults using it are about close to 40%, as you heard from Justin before, it seems the virtual ED is really being quite underutilized. And when we look at some of the demographics, the average age of older adults of the virtual ED users is 76, and we had someone as old as 102 using it, and the majority of patients are female. Also, what was interesting is that almost 91% of older adults who used the service had a family doctor, with female patients being significantly more likely to have one. So what this tells us is that it might be an indication that this group may already have high levels of digital literacy or who are already well connected to the health system, which may have served to facilitate access to the virtual ED. When we look at where the patients were coming, and it somewhat mirrors what Justin presented earlier, the majority of older adult patients, almost close to 80%, live within the municipality of Toronto, with about 13% being a little further away in York Region. But you can see that there's a small percentage of patients from other places in Ontario who use the service, with several even being out of province. And for the majority of older adult patients, Sunnybrook is not really the nearest in-person ED. And this was the case for less than a third of the patients. So this really highlights, the potential for virtual ED to reach beyond the brick and mortars of the actual hospital wall. So when we look at outcomes, there are several potential outcomes from a virtual ED appointment. And at minimum, the nurse practitioner provides health teaching on how to manage a health condition and what symptoms would necessitate a follow-up. Frequently, providers order blood work or other lab tests or imaging, such as x-rays and ultrasounds. The patient is then advised to follow up with the virtual ED to review results, which partially speaks to why 8.2% of the virtual ED follow-up is under referrals, and then the 7.5% and 9.9% for the virtual ED revisits. Another outcome is a patient is directed to go for an in-person assessment or to a specialist, which includes recommending that patients go to the in-person ED. If you could go to the next slide, please, Justin. Thanks. And so when this happens, the nurse practitioner discusses the case with the on-call ED physician. And again, this partially speaks to roughly the 24% of the ED physician consult rate that we're seeing. Next slide, please. So we wanted to do a little bit of a deeper dive where we looked at a subset of 197 patients who were first seen by a nurse practitioner and then referred to an on-call physician. And this is a group of patients that we're doing some additional analysis on. Again, because there's a lot of data. We have over 1,000 charts to go through, and we wanted to see some of the more complex cases who needed more additional follow-up virtually. So we were looking again, like what were the socio-demographics of this subset, medical history, visit details, and physician recommendations. Now, in terms of age and gender, patients who were referred to an on-call physician were similar to those who were not referred to one. So no differences there. There was no thing around socio-demographics that was pushing one group one way or the other. A little more than half, though, were accompanied by a caregiver, which may speak to older adults needing some support in accessing the service. And then about a small proportion, around 13%, had cognitive impairments, which is more or less the rate in the general older adult population from some stats that we looked up. And upon consultation, 64% were referred to emergency care and about 9% to a specialist. So overall, we're continuing to refine our analysis of this larger data set and the subset that I just talked about, but hopefully gives you a snapshot of the types of patients, older adults who are 65 years and older, coming through the virtual ED. Now, in terms of the qualitative study, to date, we've conducted 26 older adult patients or caregiver interviews, and we've talked to 7 healthcare providers. This includes virtual ED nurse practitioners, ED physicians, and administrators. And what we asked were questions about, how did people learn and use the virtual ED to either receive care, or if they were a provider, what kind of interactions they were having with their patients, what people found helpful or challenging in using it, and what could be done to improve the service delivery. Now, similar to the survey results that were presented a few slides earlier, participants overwhelmingly were positive in terms of their reviews of the virtual ED, of their virtual ED care. They perceived it to be efficient and exceptionally beneficial and compassionate. So again, similar to what we heard before, the online virtual ED allowed patients to receive the clinician's undivided attention. So it's not like they were in a busy in-person ED with people rushing around and noises. And it was really tailored to their specific personal needs being met. And older adults, and for the most part, found the website easy to use and were able to receive assistance by the virtual ED administrator on the phone when needed. So even if they were having some technical difficulties, they were able to navigate, pick up a phone, and get the help that they needed to access it. However, I mean, it is important to note that there is a self-selection aspect as in our sample, because these might be older adults who are tech savvy, who have access to a computer or smartphone, and were probably more likely to use the service in the first place. Some patients commented about them being more comfortable with technology in comparison to their peers. And so they talked about it themselves also. They appreciated being able to make same-day appointments, to see a clinician at a scheduled time, and they really commented how the service could help inform them about their medical situation and help them make decisions to know if an issue is actually urgent or if it actually required an in-person ED visit. So they talked about using it as the service as a second opinion, really making it as an important resource for health-related information. So people would talk about, well, I'm not sure if I should go to the in-person ED, so I see that there's an appointment available with the virtual ED. I'll talk to them first and then make a decision there. Another person talked how they had a family member who was an MD, and she broke out in a rash, and then their family member said, well, it looks like you have shingles. You should probably, go get to the ED and get a prescription. So, again, I don't know what the relationship was like, but she made an appointment with the virtual ED. The physician confirmed virtually that she had shingles. And because she was already in the Sunnybrook hospital system, it was very easy for her to get a prescription. The physician was able to look up her chart, and so that bypassed her from having to come in completely. And perhaps the most important benefit is that patients were able to receive the care that they needed on the same day, again, without visiting and waiting in the in-person ED. And this was seen as being particularly valuable for patients who regularly visit the ED because of an ongoing health issue. Again, there was one caregiver who talked about their father who was prone to pressure sores, so breakdown in the skin, but because of their condition, had to go back and forth to the ED. So this offered an option of still getting that urgent care needed, but without the risk of further developing a pressure wound. Now, patients, caregivers, and providers, did discuss several challenges with time, coming in, and it's starting to seem maybe to be an overarching theme, both positive and negative. While patients and caregivers were quite pleased with the interface, so the online system, some were anxious about the registration sessions timing out, as there's only a 10-minute window to complete the registration. And it's important to note that in this context, this is where maybe the medically complex issues around this patient population are coming out, because older adults may have very long medical histories, they have multiple comorbidities, they're using lots of medications. So patients mentioned having to enter quite a lot of text, which was challenging, again, if they had vision issues or other sensory impairments. So they suggested maybe a greater provision of check boxes could be beneficial to speed this up. For some patients, due to their medical complexity or, again, sensory challenges, hard of hearing, the 20-minute time window for appointments was seen to be potentially limiting. And staff actually commented a lot how this was complicated for older adults, because at times they just, had to be referred to the in-person ED anyways. There was just a lot to go through. There was that complexity, and sometimes things can go wrong. So, and this was particularly true for those of the oldest of the age group. Another challenge is not being familiar with the service. Older adults reported hearing about it by chance from a friend, from a family member, and not really in a formal healthcare setting. And some actually said that while they would definitely recommend the service to others, they got worried that it would become too popular, right? It was like, this is Toronto's best kept secret, and they were worried that they wouldn't be able to access it in the future if it gains a lot of attention and becomes really popular. Patients were often surprised to be treated by a nurse practitioner, as they were expecting to see a physician. And this really speaks to a lack of awareness about the scope of practice of nurse practitioners, that they didn't know that they could actually prescribe medications, things like that. So, there needs to be some greater awareness around this. And lastly, specialist referrals were mainly to Sunnybrook, which was challenging for older adults who live further away or who have other mobility issues, therefore limiting follow-up opportunities. And so, we wanted to know what could be done to improve this service. and this flowed naturally from some of the challenges that they flagged. While several participants suggested extending hours of operation, even up to 24 hours of availability, one provider noted that even adding morning time slots would be helpful for older adults, as they tend to be more available during the morning compared to other age groups, and perhaps this would allow for a longer time to have an appointment. Another provider mentioned that at times when they have an older adult patient scheduled for a visit, they prepare for the meeting in advance, like pulling their medical information, which does save time for the meeting. So having that, prep time is also very useful. Another helpful suggestion was providing more information on the website in terms of what to expect. So, for example, patients should have their OHIP card with them and other information like family doctor and pharmacy to avoid from being timed out. So, patients might benefit from doing a little bit of homework or prep work to make the appointment go even smoother. Again, explaining the role of the nurse practitioner and when a physician might come into play would be useful. This was something that came up. And as I mentioned in my previous slide, it would be helpful for patients to have several optional locations for specialist follow-up. As seen from our quantitative findings, for most virtual ED older patients, Sunnybrook is not always the closest hospital if they do have to travel. Finally, staff felt that they could benefit from more specialized geriatrics training, or alternatively, being able to consult with a geriatric nurse practitioner. So in terms of the research findings, the virtual ED seems to be a promising option for older adults, but there's clearly some potential barriers that need to be addressed. So how do we increase service uptake among older adults, especially those with lower digital literacy or from other equity deserving populations? As well, our data is suggesting we're likely missing that group of older adults from those communities, and that's why greater outreach is warranted. We've even had one patient say that they were very privileged and never had a hard time accessing resources. So obviously there's some opportunities for this outreach. And while some of our findings align with the previous research we did examining experiences from equity deserving populations, we did glean some critical nuances about the needs of older adults themselves, where this time it's really about some of the level of complexity that tends to be more typical in older adults. And we're not saying that younger patients are not complex, but when you start factoring the comorbid health conditions that we see, polypharmacy, where people are on 5 or more medications at any time, the hard of hearing, vision challenges, and then social factors. So if people are living alone, low income, all of these things start to culminate, which might require that older adults need a little more time and support to get through these virtual appointments. So we've learned a lot to date. So the next steps that we're doing now is trying to figure out ways to optimize the virtual ED for older adults. So we'll be hosting an in-person World Cafe in January, as I mentioned before, to bring together the different key interest groups, so virtual ED providers, community providers, decision makers. They'll let us researchers in the door, thankfully, and older adults themselves to help us reflect on our research findings. And again, we'll do these structured discussions and figure out how the virtual ED can actually plug into other models of care that our hospital is offering. We have patient navigation services for older adults to help them navigate from care. We have these hospital to home transition programs. So, Sunnybrook has really been promoting these integrated models of care, and the virtual ED could serve as a tool or an adjunct to help advance this. And again, we need to know what can be done to promote this service to older adults so that they can get the urgent care they need, but not necessarily having to come in person to the ED where they may have a long wait and a poor care experience as a result of that. And I'll turn it over to Justin to finish off.
Thanks, Sander. So just as we finish, I want to offer a few conclusions here. So we do know that the virtual ED does ease some pressure on in-person EDs by managing those urgent but non-life-threatening issues. And as we saw, 92% of cases are able to be managed fully within the virtual environment. Another key point is this is not a replacement for primary care, but it certainly is a valuable adjunct as we're continuing to try to attach more patients to primary care providers. We know that connecting older adults to community supports, whether that's mental health or social services, is another valuable asset from this program. And this does help to have an upstream intervention to or prevent avoidable ED visits. And finally, this is just the QR codes where you can see our website, which is www.torontovirtualed.ca, and as well to learn more about the St. John's Rehab Research Program here. I will stop sharing and happy to take any questions as well.
All right, thank you both so much. I've posted in the chat if you could put your questions or comments in the chat or in the Q&A box, or you may raise your hand virtually to ask your question or provide a comment. We'd love to hear from you, so please ask away. I have a quick question just as people are getting their ideas together. For the cafe, the in-person cafe in January, is this open to people? Would you have a link for folks to register if so? Oh, sorry, Santa, you're muted.
Am I unmuted?
Yes.
Okay. If people are really passionate, interested, and feel they have something to contribute, feel free to email me, and happy to invite that person to attend.
Okay, great. I'll put your email in the chat in a moment. We do have a question right away. Thank you, Laura, for your question. She says, very interesting and important work. What type of support could be offered to individuals who may have reduced technological knowledge? Or for those who may have language impairments due to stroke, neurodegenerative diseases, etc., who may not feel comfortable or able to communicate online?
So I'm happy to take a start here, and Sandra, feel free to jump in if there's other ideas as well. So one of the things that we've advocated for, and I think has been quite effective for many patients and families, is sometimes actually having a patient partner or someone else attend the appointment with them. So that might be a family member, that could be a friend, some other loved one. But we do find, not just with the older adult, but with some of the other populations mentioned, for example, those who might have had a stroke and maybe communication is a challenge, or a neurodegenerative disorder, by having someone who knows the patient extremely well and almost serving as an advocate. We found that to be quite beneficial, especially if we can see both people on the Zoom at the same time. I can give one brief example where we've had some older patients, for example, who might be living in Toronto, and they certainly fall within our geographic scope of Sunnybrook, but their family members and maybe adult children actually live in different cities. So I remember one appointment that I had where there was an older adult who had an adult son who was elsewhere in the GTA who connected by Zoom. And also we actually connected with another adult child who was actually in the US. And so we were able to have all three people here at the same time sharing information that they knew about what was maybe normal or abnormal about their loved one's presentation, and also able to hear the recommendations together. So I think that's a good example of how we've been able to navigate this. It's not perfect, but it does seem to work quite well for those who have tried it with us.
Yeah, and it's a good question, particularly around stroke, where there might be issues of aphasia and other challenges. So we do want to invite some virtual ED providers who work with that population. St. John's does have a virtual hybrid outpatient stroke program. So this is the key, is getting people who are working virtually, not necessarily in urgent care, but who are virtual providers working with patient populations who tend to be older adults, so that we can take some key lessons learned and really brainstorm some solutions that will be feasible and pragmatic, but will ultimately benefit the patient experience and hopefully increase access as well.
Great, thank you. A question from Evelyn. How does translation service work within the virtual ED?
So in our current system, one of the intake or registration questions is the patient's preferred language. So if a patient or family member identifies up front whatever their language might be, we're able to connect. We have the same system that we now have throughout our hospital or in our in-person emergency department. And we're actually able to connect to have a translator on the line at the start of the appointment via Zoom as well. So we do give the patient an opportunity to consent to that process, but we do try to arrange all of this upfront so that we're also not taking away that valuable time from the patient experience.
That's excellent. We have a couple of encouraging comments in the chat as well. I encourage you both to look at them. People are really happy to learn about this, as well as talking about the burden that people working in the ED are also experiencing. So it's important to note that as well. I had a question when it comes to kind of the older adult hesitancy of using a virtual ED, because sometimes there are two factors that we hear a lot about at AgeWell, is privacy as well as losing personal connection. So have you polled the older adults a bit about this? And if you have, what have they had to say?
So yeah, Sandra, do you want to?
So that's a good point. The privacy issue hasn't come up with the older adults, but actually in our other study around, different groups from equity deserving populations, especially those patients who don't have insurance or refugees or new immigrants, they're really worried about privacy. How is this data being used? Who is collecting it? So those issues around privacy came through in our earlier study. Around privacy with the older adults, it hasn't come up as much. I think it was more around, just getting connected. And I think maybe because their older adults tend to be high, or at least our sample are high users of the healthcare system. So I think maybe they're just less concerned about it. But that's a good point. It didn't really come up in this set of interviews that we did.
And how about that personal connection concern? Sometimes this might be, the main interaction for the day, right? For those that are socially isolated. Are you addressing or looking into any of those concerns?
So I'll just share an anecdote from a colleague from Sprint Senior Care, where they have a client. So Sprint Senior Care provides a number of services to older adults in the community, Meals on Wheels, things like that. And one of their clients is socially isolated, lives alone. And apparently when she's feeling very lonely, she comes to the ED as a point of interaction. And, it's just like, I have a quick question about my medications. So we have people coming to the in-person ED for that connection. But I think what's important is that the virtual ED won't fully replace that in-person care. They're being connected with a live person on the other line. And sometimes, again, the virtual ED is one stop in that person's healthcare journey. So, we had some patients that we interviewed would go to Sunnybrook before, do a virtual appointment, then they would have a follow-up. So I don't, that lack of connection, again, didn't come through, but people really did value the time that they were able to spend with the physician or the nurse practitioner online, again, because compared to in person, it's much more rushed. It can be a lot more stressful seeing what's going around. The long wait times adds to a lot of emotional frustration. So I think it's important that we don't lose that digital connection. But I think virtual ED won't contribute to that. I think it's just another tool that will help enhance that care experience. And I don't know if Justin, if you have anything to add around that.
Yeah, I think building off what Sandra said, the only thing I would add is a provider who has worked within the system on both virtual or in person. One of the things that I find to be able to have that great connection is a video assessment. So it allows me to see the body language. It allows me to kind of hear and see what's actually happening with the patient. And I find as a provider, it also allows me to make that connection potentially a little bit easier because I am very focused on that patient. So I know it's certainly not perfect. I don't know if there's a better technology than what we use, but it seems that this is something that resonates for those who have used it, and you can make that connection quite quickly. And I think in a more focused manner sometimes than the in-person ED, where we're constantly getting other calls and interruptions and other noises that might also detract, even though you're in person. So there might be a feeling of certain parts that are better connection, but I actually think there's parts that take away from that connection too.
Very cool. We have a question from Natasha asking, can long-term care homes access this service?
So yes, I would say it's not a service that I've seen a lot of uptake through long-term care homes, but they are certainly anyone, whether it's a provider of the long-term care home or otherwise. We have had a few where I have been on a call where someone has been at some type of institution or other organization and having that discussion. So certainly we welcome that as well.
Great, thank you so much. We don't have any other questions in the
Your
docket
hand
right
up,
now.
though.
Yes?
I see a hand up in the attendees. I
You
don't know.
do. Okay, let's see. Aha, good eye. I missed that.
I guess my eyesight's
Um,
not as bad as I thought.
so Nadine, I'm going to allow you to talk, and I'm going to ask you to unmute, and you may ask your question.
Hi there, can you hear me?
Yes.
Okay, great. Thank you both for such a great presentation. So I have two questions, but I don't think we have time for both. So my first question is, do you see the virtual ED as a potential way to expedite care for patients who may ultimately require admission? So for example, if a virtual ED assessment determines that someone needs further investigation in hospital, could this become a pathway for more direct admission rather than having a patient wait for many hours in person in the ED before that decision is made?
So really good question. And I actually have a couple clear examples of this. So we've had scenarios where a patient might come, they have their appointment or an assessment, whether with a doctor or a nurse practitioner, and we actually know quite clearly what they might need. For example, there was one patient we saw who had an eye condition, which we knew would need specialist assessment and likely admission. And instead of just sending them to the ED sort of blindly, what we were able to do is we actually paged and spoke to the specialist on call in advance. We asked them, how would you like to approach this, or what would be the best and patient-friendly option for this? And they said, send them in. We'll actually see them directly in clinic. So there are times where this happens where either we're able to get them to clinic, or in another case, I remember a patient who was a post-operative surgical patient. I spoke to the surgeon on call, and they said, oh, we'll see directly. We don't need now the ED physician seeing when they arrive, but we will arrange a bed for them. So they did see the patient in the emergency department, but arranged quite quickly for them to be transferred to an inpatient ward bed. So I think it's, in certain circumstances, I think it could be used for that purpose of what you've shared. The only cautionary component is I wouldn't want this to be seen as a way to get around kind of waiting. We want, no matter where you are, whether you attend virtually or in person, we want people to not wait long, but we wouldn't want this to be used as a way to get around that unless it's appropriate.
Okay, great. And Nadine, is your second question a short one?
I think so. I'll ask it very quickly. So I know it's with regards to the next steps for developing solutions to promote awareness and uptake of the virtual ED. I just wanted to know if you have any early insights on how potential collaborations with community-based organizations or existing partners might work. I just wanted to know your thoughts on that.
So yeah, just quickly, we held one earlier in the summer, again, around the equity deserving population group. And one of the great things about this World Cafe mechanism, again, that event in itself serves as a knowledge mobilization activity, because if people aren't aware of it, then they can't use it. And so I think our outreach will hopefully reach to different people. So like Toronto Seniors Housing Corporation, I think would be a great group to involve to raise awareness about it for their tenants. We're working with different community-based agencies. So Sprint Senior Care, VHA, are on our investigation team doing outreach with Baycrest, all these different models of care and service providers. So I think the first thing is really to build those relationships and figure out how we can collaborate. Because again, if we're not aware of it, if we don't know how we operate and sort of get a sense of who this service would really be ideal for, it's just not going to expand the way we hope. So that's really where I'm hoping the World Cafe in January will really clarify these pathways for us.
Okay,
Where the
fantastic.
answer is B, if that's shorter for you.
Yeah, the short answer.
Yeah.
I'd like to thank you both very much for coming and sharing your research and the ongoing work that you're doing to create collaborations. Really important as we go together to make sure we're not in silos and sharing our knowledge and experiences. So thank you so much for sharing that with us. And thank you to our participants for joining us and asking your questions today. We can't do these webinars without you, so we always appreciate a great audience. I posted in the chat a registration link for our next webinar next week, actually. So feel free to check that out if understanding power dynamics in research teams is of interest to you. Okay, so I'm going to wrap it up. Thank you so much. And I hope we see you at a future AgeWell event.
Thank you.
Thank you.
Thank you, everyone.